Hello and welcome to the April 2025 LLR LMC podcast. As usual, this month, I'm going to go through what's in the April LMC newsletter, just to sort of bring you up to date. This is a summary of what's in the whole newsletter. Please read the whole thing if you want to all the details. So first kicking off is that what we're getting asked very frequently about still is about the contract changes for 2025-26. I did discuss this in the last newsletter. In this newsletter, we put the details of the GPC roadshows. They're running 2 more webinars. The details to sign up are in the newsletter. They're free, and you can hear from the horse's mouth what's going on. The advice and guidance enhanced service has been now published. You must sign up by 27th of May if you wish to sign up. And if you do, you can actually claim for any advice and guidance that you've requested from the 1st of April. So first off is obviously to make sure that your practice is recording those, and then you'll be able to claim through the CQRS. The advice and guidance isn't only the one that is done through the electronic referral service, but it can also be a telephone call or an email conversation using a dedicated email with a consultant. All of these are claimable. You're able to claim only 1 per episode. So if you've had a sort of back and forth chat, you can only make 1 claim for that patient. There is a national cap on how much money there is. So obviously there's going to be a local cap as well. The ICB hasn't yet worked out what they'll be, but they've told us they could be looking at a cap for each practice. What happens after you've reached the cap, I don't know. After you just stop doing them. But the ICB is going to work with the MC about sort of trying to make sure that that's a sensible proposal when it comes out. The other thing that's been issued is the network enhanced specification for PCNs. Now, there's quite a bit of flexibility within it. So we'll leave it for you to discuss with your PCN how you're going to be implementing it this year. A lot of it has already been discussed about the increase of flexibilities, including being able to spend more on GPs, eligible GPs. And just to let you know, because I've seen this a couple of times, even in adverts where I've replied back, the GP's got to be within 2 years of CCT at the time they are employed by your practice to be eligible under the ARS scheme. Now that we've agreed and started working for this year's contract, collective action nationally has gone, but we're replacing this with local action, which we're calling protecting LLR practices. Most of it is sort of rolling on from the national collective action because, of course, there was nothing within that which was in breach of your contract. Much about it, which really should be the new normal for general practice. Say, for example, safe working practices. We hope that your practice is already doing it. If it's not, please do look at it. I have to say we've done it quite a long time ago now. We've not had a problem with patients. In fact, anything. The number of complaints from patients we have had has gone down. And I can visibly see that myself and my colleagues are sort of more relaxed because of it. So please do look at that if you haven't done that. We pick up on a couple of specific areas within the newsletter. The first being minor surgery. This continues to be a bugbear to the LMC. As you will know, as you remember, I hope, that there's been no increase in payments since 2019, which means that practices are significantly underfunded, probably by at least 50%. Regarding the service, and it does. I am concerned that the ICB continues to knowingly and deliberately underfund general practice, I presume just on the assumption that practice will just continue to provide the service. But we did the calculations and estimated that every single GP partner in LLR is paying £500 out of their pockets per year for the privilege of providing a minor surgery service to our patients. That's not on. No other business would do that. And I can't actually imagine any other industry in the world expecting that. We are working with other local LMCs about a combined approach to this, but in the meantime, within your practice, have a look at it. Look at what you want to do. We've made some suggestions. At a recent meeting of GPs, I did a quick straw poll, not very scientific at all, but of those GPs present, the vast majority of their practices have changed what they're providing. And they are now cherry picking. So they're going to do procedures which can be done within the amount of money that's being funded. And others are just referring to secondary care, which is bonkers, as we know, because actually, it's going to cost the area, the health economy, an awful lot more for each of those patients, as well as being inconvenient for them. It really does not make sense. Just taking that one thing, if you look at minor surgery injections, the hospital receives over £600. We receive £45 for doing exactly the same service. I mean, how can that be justifiable? So please do, within your practice, discuss that. Within my practice, we now have a waiting list. I am sending back requests that I wouldn't before. So say if a patient has been to rheumatology or orthopedics and they say this patient just needs a steroid injection, could you do it? I'm just writing back and saying no, because the funding isn't appropriate for us to do that. You're going to have to do it yourself, which of course is just costing the NHS more. So I really cannot understand this. The other area which we pick out is Lucid. So this is more of a recent service. And after a long time, we've eventually got the costings from the ICB because we thought it looked a bit light. We've gone through the costings again. They've just taken sort of blank hourly rates for staff, and they've not added on any on-cost whatsoever, which is just totally inappropriate. So we estimate that they are underfunding the service by more than 80%. Yep, more than 80%. Within the newsletter, I have given a breakdown of how we've approached this, just so that you can understand how the LMC is doing this, and you can see that what we've asked to be put in, is appropriate. We're not asking for the earth, we're not asking for a massive amount of profit. I hate to mention the word, but how dare GPs actually earn more from doing more, for providing more services? I don't know why there's such an antagonism towards that. Again, there wouldn't be, I don't think, in any other industry. And then sort of moving on, this month, we've got a couple of updated guidance. The website has got an awful lot of guidance that we have added to it over time. If you ever come across anything which is out of date or you think needs improving, updating, do contact the office and we can do that. So the first one that we've updated is the pre-travel advice. Now we've done this because there's been some confusion, because pre-travel advice isn't just the vaccinations. It includes an awful lot more. And if your practice is providing pre-travel advice, you do need to make sure that you're providing the full service. Otherwise, I think you might be open to criticism and even possibly open to action. So there are the vaccinations that every practice must provide as part of their GMS for travel, but then there's vaccinations that we don't, and then there are other health advice that you might not think about doing at the same time. So you advise about using suntan lotion, something as simple as that, but maybe another one would be say malaria. your nurse or yourself, you've gone through, you worked out what vaccinations they've done, but you haven't mentioned to them about the fact that they're traveling to a malaria bout, that they do need to take precautions and they do need to be taking prophylaxis. If the patient then came back with malaria, then I think that would make you liable. And of course, it is a private service if you set it up that way, and so you will need to have separate indemnity for it. And the second bit of guidance that we've updated is regarding shared care agreements. So what we've done to add to our previous guidance is that we've now added a letter that practices can give to patients to explain the reasons behind why a practice may decide not to continue prescribing a medication that has either been started or advised by a specialist. There's sometimes very hard conversations with patients, and we're hoping that the letter is going to help you in that. You might again need to consider a policy regarding this, because what you don't want to do is that you don't want to be open to being criticised for discrimination. So you need to say, actually, we're actually using the same approach for every single request for shared care. The next thing I'd like to tell you about, a bit of good news, is our pastoral care service. So, we've been providing this for quite a long time, but we've not done it as a as a considered discrete service. So we're now launching this. It's all described in the newsletter. So basically, we provide help for individuals and practices who have got into trouble. This was previously led by Dr. Shiraz Makdar, and he has actually agreed to continue in the new role to provide that service. So he oversees it, but it might be someone else from the team that actually provides you with support, particularly if there's conflicts. If you know Dr. Makdar, we have plenty of other people who are ready, able and willing to provide you with that support. Please look through that, and please remember the LMC. If you get that letter, the letter from GMC, which are still abusive, or contact from the ICB, or you're in a practice dispute, or similar. We can't give professional advice. We cannot give accountancy advice. We cannot give legal advice. We cannot give HR advice, but we can give some support and some sort of signposting, and to give you the benefit of our experience. The next one is a bit of a mythbuster. For some reason, somewhere, bizarrely, out of the blue, I got contacted by a practice because they got told when they completed an MCCD that they had to have viewed the deceased in person during their lifetime. Now, this is nowhere within the guidelines or legislation. There's no requirement for this. Took a bit of time to unpick. I found, following the trail, that it actually had come from our regional medical examiner, who was advising this areas to take this route. And I contacted them directly, and I've had a Teams meeting with him and explained why it's inappropriate. And I put our reasoning actually in the newsletter as well, so you can see that. And it didn't take long for basically for them to agree, which was also helped by the fact that the national medical examiner has similarly written to the regional medical examiner and to our local medical examiner, saying that what has been proposed was out of line with the national requirements, national guidance and legislation. So it's back to business as usual. As long as you have attended the deceased during their life, then you are able to complete the MCCD, which basically reflects how modern practice is now done in general practice. So finally, LMC events. We've completed all the events for last financial year, and we're now looking to start booking them for this financial year. I've put a list of suggestions in the newsletter. Please look through them. If there's a topic or an area that you think would be beneficial to practices, do let us know, and as far as we can, we'll try and put these things on. When you're doing that, also tell us whether you think it will be best done by a webinar or in person. Webinars, we find more people sign up to them and they're a bit more convenient because you're not got to get to a venue, but in person is much, I think in some ways is more beneficial. You get much better interaction. So if you can, do attend one or more during the year. The LMC is, though, financially supporting again the annual conference of local practice and PCM managers. And if you're a manager and you're going along to that event, do come and see us. So we are going to have a stand there. Charlotte's going to be there all day. I'm hoping to be there for at least part of the day. So do come along, come and say hello. Tell us what you like or don't like with the LMC. And tell us what else we could be doing to help you to make your work life easier. So just come and say hello. So that's the end of my podcast for this month. I'll be back again next month. And as I say, do keep your questions, your comments, your queries, your exasperations coming into the office. You can contact me directly, but if you can send everything through the inquiries email address, then we can make sure it gets to the right person first time, as we're all trying to do in our practices as well. So see you next month. Bye then.